Good evening, everybody, and thank you very much for coming along to our West 29 LMC annual general meeting. Those of you that don't know me, I'm Dr. Hannon, I'm the chair, and thank you very much for coming tonight and staying 2 hours with us to hear a little bit about what we're up to in the LMC, and in particular, I think we're very, very fortunate to have Tista from GMC to come along and talk to us a little bit about what the GMC is doing and some of the challenges that we've got around regulation, what the GMC's view on this is, and perhaps an opportunity for us at the LMC to look at what our role could be in trying to support local GPs and local practices to try and make sure that we continue to deliver high quality, safe services. So without further ado, Tista, thank you very much.
Thanks, Amit. Just what vertical laptop? Okay, evening all. Can you hear me clearly or should I use the mic?
I can hear you.
Right. Okay, so as Amir said, I want to focus on the direction of travel with the GMC today, the direction of travel in terms of regulation. But before we start that, by way of brief introduction, for those that don't know me, I've been in and around healthcare for about 20 years now, originally working with survivors of abuse in services that have now been subsumed into the SARCs, the Sexual Assault Referral Centres. Then did some work on advocacy in 2005, and then around about 6 years ago, I was asked to join the GMC, ostensibly to help drag it out of the ivory tower and actually engage with doctors and colleagues on the ground. And I think that's working. It's been a good 4 years since I was introduced onto a conference podium to the theme of the Imperial March, Darth Vader's theme tune, for those that don't know. And that was GPs, who I find have particularly a certain sense of humour, I have to say. But always good fun. And the serious point behind that, of course, is that we are thought of predominantly in fitness to practice terms. And I understand why. As a regulator, over time, we went too far in the other direction, shall I say. You will be aware, no doubt, that there are a number of scandals in the 90s, and the GMC was under a great deal of scrutiny. Chief exec at the time, rightly so, needed to stabilise things, but in so doing, as has since been recognised publicly, we did go too far the other way, and unfortunately it disenfranchised much of the profession. And then when Neil Dixon came on, our latest, most recent chief executive, he recognised that. And he realised that we needed to change the narrative, we actually needed to work with doctors. Some of you might remember, in fact, that our former strapline, for want of a better word, used to be something along the lines of protecting patients, regulating doctors. That's just massively negative. And what we now have is what it should be, working with doctors, working for patients. We're not all the way there, we'll start exploring that as we talk this evening, but there have been significant changes. And of all our functions, I cannot emphasise enough that standards is the fulcrum of what we do, and I would argue that actually it's far more important than fitness to practice, far more important. And I'll detail that as we go through. Having said that standards is more important than fitness to practice, however, I want to start by looking at some themes around fitness to practice to put things in context, and then talk a little bit about how we need to move. So you might be aware that the GMC fairly recently saw an exponential rise in complaints to us, to the point where they doubled in 5 years. Happily, over the last 2 years, we have started to see a reduction. We don't know if that trend will continue, but we think it's relatively likely. Reasons behind it, hopefully our messages are getting out there about thresholds. But then perhaps society is changing as well. We will see. Now, to avoid any postprandial mapping and to get us thinking, you'll notice that you have voting buttons at your table. Okay, so take another minute or so to wrap up your conversations. It is working again, but it would be unfair to stop you and said we can have that discussion.
Maybe it's different. I think the doctors need more support. I never even complained. The nose field is having but we need to support the doctors. Is more look after, more care, focus on the patient than the doctors. And the doctors see lack of support.
So did everyone catch that when a complaint is received, there is a feeling that more support is needed from us at the GMC? There is too much focus on the complainant, whoever that might be, rather than support for the doctors. And has anyone seen, that is absolutely the feedback that we get, has anyone seen a change in emphasis over the last 18 months or so around that or not?
The letter's a bit softer.
The letter's a bit softer.
But it doesn't really alter the content.
No, it doesn't. And it's never going, I think, however the tone of voice changes, and I do think it still needs to, I think it needs to be softer still, it's not ever going to be a nice message to receive, is it?
And I think the other thing is that those complaints that the GMC deem not for them to investigate, the automatic referral to GM or whoever, I don't think that's helpful.
Yes. Okay.
And I don't think they handle it particularly well either.
Okay.
I'm over in the corner, but I'd like to endorse what Elizabeth said about the GM at this level. I think the GMC actually do unleashing the GM, but the overwhelming people feel. So what's happened is that they feel that they're being just as guilty and have to prove that they're innocent, which is not the way we should be supposed to be in this UK.
No, absolutely not, because as with any service, whether you're looking at criminal or whether you're looking at tribunals for any profession, it has to be innocent, but before proven guilty. But I wonder if it's always going to feel like you're guilty, because whether you're lotting at criminal or otherwise, it's always going to feel terrible. That's not to say that the GMC, other organisations shouldn't provide more support to try and change that emphasis, because we know that it's going to always feel terrible. But I think insights from LMCs, because of the pastoral work that you do, is something that the GMC needs to take on rather more to see how we can change those emphases. I want to pick up on some of the other points that were raised as we go through around complaints that are referred, for example, to GM, etc., and proportions and things like that, to see if we can provide some reassurance around that. But if we pick up now where we left off before the technology let us down, and hopefully those questions will be answered as we go through. Okay. So I shall close polling. Let's see what we've got. Okay, I'll move to this side so that everyone can see a bit more clearly. Right. So final numbers in. Okay. The winner, for want of a better word, is actually psychiatry. And I'll show you, in fact,
not as with knives.
By far, the most complaints are in psychiatry. Then there's a bit of a drop and you're looking at obs and gynae, surgery and GP, as I pretty much said. It's interesting because people do often think it's paediatrics. Paediatricians certainly think it's paediatrics, but paediatricians do quite well because there is a significant drop again before all the other specialty groups. Okay. And then finally, you have pathologists who don't get many complaints. What do you expect? Yeah, asleep or dead, yes, I know.
What is the figures for upheld complaints as opposed to people making complaints? Psychiatric patients very often complain very loudly because they've turned up a month late and they're wanting it back, so that's part of it.
Exactly.
But what happens when it comes out to upheld complaints?
Yeah, it is proportionately, it is slightly higher than certain other specialties, especially if you look at the type of complaint. So if there are boundaries, complaints around boundaries, you do see a higher proportion of upheld complaints around boundaries issues, relationship with patients, that kind of thing, in psychiatry. You do see slightly higher health issues in psychiatry as a specialty as well, including substance misuse. These data come from a publication that comes out every year, around about October and November, called The State of Medical Education and Practice. And that's really genuinely interesting. It cuts data in a number of different ways. And I think for the GMC, it's really important to share it and put it out there because it can help inform what we need to do. We, not just being the GMC, but colleagues on the ground as well, to prevent. You'll have seen the quote that I used for the title of the presentation, the Benjamin Franklin quote, prevention, worth a pound of cure. And I think we have a responsibility to use our data in that way. Now, having looked at proportion around specialty, next question for you, not a voting question. What's the most common complaint from members of the public, the most common theme?
Attitude.
It is. It's communication. A number of things around communication. And just to provide some reassurance around that, the vast majority of complaints from members of the public don't go the distance with the GMC. Members of the public complain most. About 60% of all GMC complaints are from members of the public. How many of those meet our thresholds for investigation, would you say? What percentage?
20%.
It's 15, in between. Yeah, 15%. And that tells a story straight away. And one thing that we've been trying to do for some time is work with patients and public organisations to explain that the GMC is there for fitness to practice when it comes to complaints. And actually, I think it's always going to be a very difficult message to land that, yes, your doctor has made a mistake, but he or she is fit to practice. And it's embedding that message that we're all human, we all make mistakes, it's not a reflection, a mistake itself is not a reflection on fitness to practice. So, whilst I think we will always have a huge proportion of complaints from members of the public that aren't for us, we're hoping that the message is getting a bit clearer, perhaps as patient and public infrastructures, which, let's face it, particularly in primary care, were decimated, well, more than decimated with the Health and Social Care Act, as they start to sprout up again and grow stronger. Hopefully they'll have other avenues to go to and not straight to us, because it's not appropriate. Yeah?
Can I just say, a few years back, if the patient is not happy about anything, they put a complaint to the surgery.
Mm-hmm.
Now they don't do that anymore, they're straight to the GMC.
Yeah.
You know?
Or an HSE. And
Yeah, exactly. We used to sit down and, with the patient, sort things out, sort it, rather than waiting for a year and a half to.
Absolutely. Yeah, and this is what we want. Things are best handled locally. Even if there are performance issues, in the vast majority of cases, it's best handled locally.
Yeah.
Yes.
In Space England, is there sort of reasonableness before you take things forward and investigate?
Yes.
So if something's not considered to be reasonable, would you say to the person, you really need to go back and see
Yeah.
the surgery directly?
So, of the 10,000-ish complaints that we receive every year, 50% are immediately closed without referral to GM, for example, or to the employer, if you're looking more broadly. And yes?
Do those doctors actually know that complaint's been made?
Now that's a really interesting question, because you have a right to that information to know that a complaint's been made, but on discussion with a number of organisations, including the BMA, it was decided a while ago that those complaints that are clearly not relevant, not about fitness to practice, doctors wouldn't be informed routinely unless you ask. The feedback was that, for example, if someone was complaining about waiting times, things like that, it would be, it would just be an extra stress to know about it. There are those that agree, there are those that disagree, but the majority felt that they wouldn't want to know, in the knowledge that they can write in to check if there have been complaints. Ultimately, those types of complaints can't be used by the GMC anyway, because we've decided not to pursue it. So, huge proportion not used, not looked at by the GMC, closed. We tell the complainant, go back locally, this is the avenue that you can use, it's not for the GMC. Then there's a proportion that is that's clearly not for us, but might be useful for the doctor, might be useful for the employer, and that's when a disclosure is made to the doctor and to the employer. And then finally, about 20%, 25% are actually investigated. But I'll come back to the figures on that, because again, there's a drop-off rate after you start the investigation. What I just want to pick up though, we've talked a little bit there about what patients are most likely to complain about. Didn't surprise me that it's around communication, because that's kind of the direction of travel. It's reflected by other regulators such as the General Dental Council, those in other countries with a similar style of practice to us. What did surprise me was the next question. What do you think is the most common complaint from colleagues, including employers? Yes, do pick up your voting cards again. I'll check it's going through. The projector's not showing me. Okay. Okay. Quite a mix there in responses, and actually, probity. Yeah. And probity, what kind of issues do we see around probity? It's a mix of things. It's not plagiarism as it happens, although that does feature. I use that cartoon because appropriately it was copyright free. The kinds of issues that we see most frequently are actually saying that you're sick and then doing locums, things like that. But most common is making a mistake. And actually, that mistake, as we've discussed, is a mistake. It's not a fitness to practice issue. But then covering up and covering up and covering up. And that's incredibly common in the cohort of probity complaints. Interestingly, that issue is far more prevalent in our more recently qualified colleagues as well. and that's very much worth noting. There will be multifarious reasons for that. I'm sure data only ever tells part of the story, but we are increasingly concerned that one of the reasons behind that is what I was talking about before, perception of the GMC, the fact that we did perhaps go too far the other way a while back, and what people are learning from colleagues, from the system.
When you say early, new, is that trainees or is that newly qualified GPs and consultants?
Doctors in training primarily. In fact, if you look at F1 and F2, that's when it's really, really high, then it drops off gradually. Now, it's a shame because these data, we only started collecting it around 2012, so we haven't got, we'll have comparisons going forward, but we don't have the historical data, so was it ever thus? We don't know.
Can you give an example of the kind of thing that someone covers up that's very serious?
I'll tell you a story in a moment. We're very concerned that the reason behind it is people make that mistake, and because of the stories that they hear, not always accurate, instead of dealing with that mistake as you would do effectively, fear drives people into weird, strange behaviours. We know that can happen. And I'll tell you that story. I was at a conference once, and the speaker before me was a medical defence colleague who was explaining how we all need to have indemnity insurance, absolutely true, and her example was that it's especially important these days because of one of her clients was given a warning by the GMC for accidentally knocking off a wing mirror. And I sat there and thought, well, that sounds incredibly punitive and ridiculous. That can't be right. And of course, I was a speaker after her, so the conference hated me by then. But eventually, I was able to look into it. And a doctor did accidentally knock off a wing mirror whilst doing the school run, dropping his children off at school. And someone in the neighbourhood saw, took down the vehicle reg, rang the police. Police rang the doctor, and he said, no, wasn't me dropping off the children that day, it was my wife. At this point, the doctor has far more to fear from his wife than the GMC, frankly. And, you know, this is clearly not a fitness to practice issue. Clearly, you all know that. Anyway, the police had no reason to disbelieve him. And apparently, it was a few years ago, because I don't think they do this anymore, but they went back to the witness to give feedback. And the witness said something along the lines of he, him, and the police thought, oh, saw the driver, and the driver was male. What's going on here? So they rang the doctor back. And he doubled down. And he said, no, it really wasn't me driving that day. It was my wife. Look, I can prove I was in work. And he retroactively amended records to try and prove that he had been in the trust. And that's what he got the warning for. And when I first heard this, I spoke to one of the lawyers involved, and she said you could see everyone in the room just wanted him to say, I'm really sorry, I was so scared. But he couldn't bring himself to. And I felt terribly sorry for him. And I'm not generally soft, but I thought, really, to feel that fearful is an indictment. It's really sad. But I remember, in fact, when I was teaching some of NAB's trainees, and I was telling that story, one of them said very clearly, no, this is absolutely terrible. I don't feel sorry for him, because what else would he lie about? And I expect that was the thinking when it comes to these probity concerns. Nonetheless, as I say, it's an indictment when people can be that scared. And I'm going to share with you some quotes from some F1s that I taught a few years ago. which they let me use. Because they were really surprised to find the true picture around fitness to practice, around complaints and what the GMC role is. You'll see that some of their impressions are clearly from medical school, where med school has used us as a lever to try and get what they want. But that's just depressing, isn't it? That last one. And are we in a place now where, in a society that is more litigious, in a profession that has become more fearful of the GMC, that this kind of thing is perpetuating? Okay. And actually, that is the percentage of doctors where annually we see really serious fitness to practice concerns. It's a tiny minority. Tiny. And consequently, logically, but most importantly, morally, our focus must be on standards. It must be on the support. It must be on what we call upstream regulation. And that is rooted in a lot of work, a lot of research, but done by the likes of Prof. Sparrow, not Nigel, Prof. Malcolm Sparrow from Harvard, who works an expert in regulation. And he rightly says that regulators have to focus on working with their professions. Ultimately, if a regulator is there, well, if we are there striking doctors off, then we've failed, haven't we? What we need to be doing is supporting doctors early on in an environment that's increasingly difficult to try and prevent problems. And yes, this is a paradigm shift, I appreciate for many colleagues, and I don't think we are all the way there yet. I think there have been significant changes that haven't permeated fully. I think there are more changes that need to continue. But in terms of those changes, this was where I was going to ask you to break for a bit of conversation. So what I'll do, I'll just update you on some of those changes before moving on. That support that you mentioned, to some extent, it would be a conflict of interest for the GMC to provide support when someone is being investigated by us. However, in recognition that that support is needed, we have commissioned the BMA to provide doctors for doctors support services, whether someone is a member of the BMA or not. Are you aware of that as LMC members? Because what's interesting, we find that most colleagues on the ground who aren't particularly active in any BMA groups or LMCs aren't aware of this, particularly trainers, because we're very keen that trainers let trainees know about this so they know early on that lots of support is actually accessible if they are in difficulty. So that service exists, Your Health Matters exists, because, just because you're ill, it doesn't follow that you're not fit to practice. So there's a lot of support around there. There's the work that we've done, many of you will know Lewis Appleby. There's the work that we've done with Prof. Appleby to improve processes for those that aren't well. And then there is work remaining that needs to be done on the process itself, and referring to some of your points. Tone of voice is better, but it really needs to change more. It's still legalistic, and those letters, they're not letters, they're big bundles, and it's going to be horrible to receive whatever happens. So it does need to change, to just be a bit lighter, so people don't feel quite so bad, and make it absolutely clear that support is available from the get-go, so people access that immediately. What else I think needs to happen is People need to be made aware of thresholds immediately, so that when they get that awful letter, they'll realise, well, actually, 0.05% of serious, that there are 0.05% serious issues. So actually, this is probably going to be okay for my career, rather than my F1 who thought anything, any mistake, any infraction would be the end of her career. So there is plenty of work to be done, but it is worth having a look at what work is ongoing, and it is worth LMCs feeding in to those projects with your insights from the work that you do with colleagues, because we do need that, and there is forum to do that on the website, but also through face-to-face consultations with the likes of my team. Okay, so developing on from that conversation, I want to look at how we get upstream. I've talked about support once someone is in difficulty, but actually that's not upstream, is it? So how do we get upstream? There are a number of initiatives. Is anyone aware of Medical Professionalism Matters? Okay, no. I'm taking that as a no. It's collaboration between us, COPMed, BMA, a number of colleges, and it looks at a number of facets of professionalism, and the one that I've chosen to highlight from one of the workshops is the one that looked at support for doctors, the environment and resilience. There's a lot of research and good work in this collaboration, but this is very much longitudinal. It's not an immediate initiative. There are good reports on it, but as we know, with all of these things, it will take time to embed. By all means, have a look at it and continue the conversation. You can do that at the website. And I would urge you, I'll share these slides later so you have them, but I would urge you to do that. It's genuinely interesting work. But more immediate initiatives that I'll talk about. We all know that in this country, like a few others, we have a history, don't we, of inviting doctors from overseas, dumping them into the system, and not providing all that much support. And then they might encounter difficulties. Surprise, surprise. So we created Welcome to UK Practice in order to support these doctors, because what we find is whilst everyone has to go through induction, it's about fire and lifting and things like that, rather than, well, the law's very, very different, and there is such a thing as Gillett competency, etc., etc. And it's these things that people need support with, as well as networks and that side of it. So, Welcome to UK Practice is available to all, but unfortunately, rather like some of the changes we want to make to fitness to practice, we can't because the law prevents us. So we can't mandate it at the moment. It is therefore just still an invitation to those joining the register. Does make a difference, and we've seen that feedback from those who have been on the course from 5 years ago, they have found it still to this day, that grounding has helped them. Then there are other initiatives like Duties of a Doctor. Duties of a Doctor is a 6-month programme that is available to all colleagues. The idea is that over that 6 months, work with one cohort of doctors to provide support around the practicalities of turning that abstract guidance into reality on the ground, because it can be difficult, especially in this environment. And we've done quite a few of these programmes in secondary care and mental health. We haven't as yet in primary care, because the system is finding it too difficult to release colleagues for that period, one half day even, over 6 months. And that, well, it's telling in itself, isn't it? Because we're really keen to find a way to to work with primary care, to learn from primary care what would be useful and put something on. So I would welcome your views and your thoughts on that. And we would be happy, well, I would be happy for anyone in my team to work with a small cohort. It doesn't have to be 20, you know, because I think it's something that we need to learn and see what would be most useful. Okay. And then there's the other work that we do on the ground on promoting excellence and good medical practice. And when I say good medical practice, I don't just mean that document there, but all of the other guidance that flows from it. It's not all there, I can't fit it all neatly onto a slide. But just to share some learning with you from our work on teaching around these areas. One common refrain is that there are so many pressures in the system. I'm really busy, absolutely true. Have to keep up with nice guidelines, ever-changing local pathways, etc. Haven't got time to keep up with all of this. And isn't it all common sense? That term, common sense, is used so much when people talk about good medical practice, and I think that's because good medical practice, the core guidance, is common sense, largely. There's precedent for that, though, whether you're looking at Hippocrates or Paracelsus. It's wise to highlight the fundamentals like first do no harm. But what I will point out is that guidance goes into a lot more detail, and don't try and read this. This is the point of this slide. This is a list of every single piece of legislation that we distilled to put into just one piece of guidance, in this case confidentiality. And that means, effectively, you either need to know the confidentiality guidance, certainly not verbatim, but these themes covered therein. Otherwise, you are actually expected to know every single piece of legislation here, including things like the Radioactive Substances Act, which is just ridiculous and impossible. It is impossible. And that's what the policy ethicists in the office, rather than my ethicists on the road, do for you. They look at the wider ethical framework, they look at the relevant legislation, they look at what's salient to medical practice, and they put it into a more digestible document for you. And consequently, that makes it the benchmark for fitness to practice. But as an ethicist, more importantly, from my perspective, it supports safe decision making for you and your patients, for your wider public. It promotes those values, those behaviours that we want to live up to. That doesn't mean it's easy to keep up to date with it all. And I'm just going to share examples of that with you now, just a few. Over 2016, we collected data on what people were aware of. So, for example, when teaching on capacity, and the sample size here is between 5,000 and 7,000 doctors across all these questions. So, when teaching on capacity, 37% of colleagues presumed incapacity where a patient had learning disabilities or condition like Lewy body dementia, for example. I will caveat these data by saying that they're not stratified in any way, they're not weighted. The majority are actually doctors in training. Majority, around about 70% doctors in training, but it's a snapshot, it's a starting point for conversation. Then, when we look at best interest decision making, 62%, and this was a significant majority for doctors in training, hadn't realised that best interest decisions had to consider more than just the clinical best interest, the clinical benefits, burdens and risks, which was interesting. And 64%, and this was purely doctors in training, were using WhatsApp without realising that confidential information, it might not be a secure platform for confidential information. And this, well, I'll share one more example with you, but I'll do it slightly differently. Just to keep us thinking rather than me just spitting statistics at you. This is one of my favourite cases that I use, and it prefaces the next bit of data, and I thought we'd consider it to keep things interesting, as I say. I mentioned I used to work with survivors of abuse and still give advice to this day to the SARC. And Talia is a composite of many of the cases that we've seen, that we still see. Okay, so that's the history. She doesn't want to go to the police. She doesn't want her partner to know her HIV status. And she doesn't want her GP to know her HIV status. Now, question for you. You can imagine yourself as out of hours if you prefer, or as the gun clinician. The majority have it. With this question, or these themes I should say, because it's not always the same case of course, we actually find that our younger colleagues, our doctors in training, are more frequently correct with this one. And I don't know if that's a change in teaching, a change in the wider, I don't know, but that's interesting. The pushback, of course, tends to be, well, how can I ensure that I'm safe, my phlebotomists, etc., are safe, but of course the answer to that is standard precautions, and you may well have a Talia who does not know their status, which is why we treat everyone in the same way. But the legal position is that if someone's adamant, then you can't breach their confidentiality to tell their GP. There is usually a workaround, and usually you'll manage to reassure people that the GP has the same duty of confidentiality, or if that fear is so high, you can suggest other things, out of hours GP, another GP, whatever. Okay, around the safeguarding issue with domestic violence. There's always a mix with this question. Everyone's going to make their own assumptions before you answer this question, so therefore it's never going to quite be definitive. However, if we take this vignette to mean that you can see that Talia is competent, she doesn't have any children, and as far as you're aware, you can't see any escalation in the violence, then it would be C. Okay. And that is that chimes with the Care Act 2014, and what we've started to see since the Care Act, since adult safeguarding services have improved, we've seen more people go with C. Doesn't make it easy, and of course there's a lot to discuss around issues like this, and it very much depends on the individual in front of you. It's never a picture with a few bullet points, is it?
So when would you break confidentiality?
If you are concerned that there is escalation, if you think, actually, I think that the risk now is of death or such serious harm that, that there's no coming back from it. So that's when you can. A lot of the time, though, in these situations, it's going to be so finely balanced. If you're uncertain, what would you do in reality?
Ring your defence.
Yeah, that's it. Absolutely. Whenever there is uncertainty, it's good to get a view from defence colleagues. Who else could you ring?
I would have an anonymous discussion with somebody from safeguarding.
Yeah, absolutely. Yeah, adults say, and you'll have this in child protection, although in a way it's easier for child protection. Yeah, safeguarding. Safeguarding colleagues are the experts with this, and they can really help you. Just to add to the point about defence as well, do you know that the GMC, albeit not 24 hours unlike defence, the GMC has an ethics helpline? And that can be very useful to talk these issues through. The SARC ring me. I'm not the ethics helpline, so please don't all ring me. But the SARC, because I consult to them, they ring me quite regularly when there's something really difficult. And you can do that with colleagues at the GMC, absolutely. The final, in some ways, the hardest, then. So you've done everything right, of course. You've explained to Talia that really she does need to tell her partner, that you can support her through that, etc., that you can get her somewhere safe. She's adamant, however. So in light of that, now, there's no right answer to this one. And in these situations, we still have rooms of very experienced colleagues split 50-50. And that is because with issues like this, it is down to the person in front of you and your professional judgment of the situation. And it's where I always say, use the guidance as an algorithm to help you consider what you should and must, to use the vernacular of the guidance, consider, and then having considered all of those, weigh it and come to your decision. Guidance isn't edicts from up on high. It is there to support decision making, albeit that it is rooted in the law. And then, with a situation like Talia, I'll come to that 93% in a moment, you would look at the public interest test and you would weigh what's the benefit to her partner or wider society, because of course her partner may be sleeping around, there may be other issues, versus the harm to Talia. You'd weigh those. What else would you have to weigh on this side before you can decide which side of the scales is heavier?
One of the challenges is if you did break confidentiality, then will you end up being referred to the GMC? It would be a major threat to any individual and can affect our career. So I think it's not just about the individual, it comes back to the GP as well.
Okay, let me come back to that important point, because that's been raised with me quite recently actually. The other consideration here is not just referral to the GMC, it's actually that wider public interest in having a confidential medical service. If you imagine that a ghost service or a sexual assault referral centre gets a reputation for being leaky with confidential information, then people might stop presenting. And there's a great risk in that. So that's all the thing. Those are all the factors that you're weighing. And having weighed those, You can make your decision, but I would say, as per our colleagues here, it's not one that you're going to make alone. It is too finely balanced. You would get a sense check. You would always get a sense check. And what I wanted to highlight, this public interest test, I remember years ago, before it was termed really the public interest test, that's what we would use for decision making. And I just assumed it was in undergrad curricula, but 93% of colleagues where we've, across the country where we've taught on the public interest test had not heard of the public interest test. And all of this isn't me standing here saying, God, isn't the profession terrible for not knowing all of this? It's an indictment of a system that doesn't afford you the bandwidth to keep up to date with these areas that can help with decision making in very, very complex situations. Then there are other complications, as Andrew's pointed out. There is that fear factor, and to go back to that very specific point, well, if you have considered all the shoulds and musts, and make your decision from that, well, as I said earlier, that's your safety net. And it's not just Talia's safety net, it is your safety net as well. And whatever happens down the line, you have demonstrated that you have followed the required standards. That is the best thing that you can do for your patients. And it has that ancillary benefit of being your safety net. So, and then just very briefly, restating our thresholds. You know, making a mistake on an ethical decision, making a mistake, single clinical incident, that kind of thing, that does not meet our thresholds. It's not for us. Anyway, back to what I was saying. Something needs to change to help colleagues keep up to date with all of this. So, your insights, sorry, the anonymous thing is covering up the option there, but it says guidance for trusts and NHS England. Okay, any responses in? I'm really pleased and entirely unsurprised that no one said okay. Some of you will know Shirley Remington at the Deanery, and she was really strong and absolutely rightly, I feel, argued that the GMC has a role in going to trust boards, and perhaps indeed NHS England as well, and saying, look, this is what you need to support staff with. These are all the things that they have to know, that they have to keep on top of, and they don't have time. So you need to accommodate for that. And I do think that there's something around there as well. And more time always wins, you'll be unsurprised to hear. And that brings me to my next point, and apologies in advance for the levity in that cartoon, if you can see it, but I started using it when a friend of mine, a senior trainee, who's involved in lots of leadership things, so he absolutely should know better. I was chatting to him one day and he said, oh God, I was really, really ill this week. And I rang in, but my consultant said, no, please, you have to come in. And he lived 40 miles away from that rotation. And he did go in and he said, but it's all right because I triple checked everything. And we all see that because Sometimes the service runs on goodwill, doesn't it? But it's not right. It's not right. And it's something that we're very conscious needs to change. Great, the GP, the service has been on a precipice for years, and finally, we have GP forward view, but I don't know, lots of people say it's too little too late. I don't know what your thoughts are. We have the GP health service now from this year. Great, and that is great, but colleagues around the country still feel like this, like Sisyphus. And that brings me to my next question. A couple more seconds. Okay. Right. This question was a bit of a red herring. And I'll explain that. Next question, sorry, that's covering up again, but if you're struggling to cope because of pressures on the system, basically, could you ask for help, do you feel, without being penalised? Now that's depressing, isn't it? So what's happening here that isn't happening here? There's learning there. And I'm going to share, this isn't a voting question, I'm just sharing with you the results from 2016. And this is across all grades, not predominantly doctors in training. Interestingly, the big conferences that we had across the country on this topic, which had some very, very senior attendees, we did stratify those results. And of course, those very, very senior colleagues were all agree or strongly agree. SAS doctors and doctors in training were predominantly strongly disagree. And that brings me to resilience and what we mean by that, because resilience is not grin and bear it. It really, really isn't. This is a still from a video that I mentioned Shirley Remington before, Shirley at Deanery and Mark from CMFT, Mark Forrest from CMFT, pulled together on resilience, and it's just a few minutes, and it's worth a watch. It's genuinely interesting, and it links and signposts to things that you can do. And resilience, what we mean by that is being able to deal effectively with those pressures, not just coping with more and more pressure, but for example, recognising, no, this is too much, there's risk of burnout. So I'm not just going to carry on, I'm going to do something. Recognising, actually, 7 minutes is really not enough for a proper shared decision-making consultation. So I can't just keep on doing more for less. And it's having effective ways to deal with that and not in isolation. In some ways that's easier said than done. There's clearly a lot more to explore around system issues and pressures. It started now, but as I said before, I've been hearing about GP being on a precipice for years. And it's only just being officially and formally recognised. So, whilst there is value in resilience, because we do need to be able to cope in this ridiculous environment, there are absolutely, as you recognised in your voting and said in your voting, that there's other considerations as well. And that brings me to my wrap-up point, which is a bit of a reflection on reflection. I won't go into detail at all about revalidation, but just to say, as a refresher, revalidation was never there to catch the shipment or, catch out poorly performing doctors. We've seen that it's a tiny minority that have serious fitness to practice issues. Rather, one of the big aspirations behind revalidation was to promote reflection. And I don't just mean personal reflection. On that note, just thinking slightly tangentially, don't shout out, but raise your hand when you see what the error is on that slide. You've got 5 more seconds. Okay. It's really frustrating when you finally point it out. Was it Andrew or Alan who was first?
I've seen some evidence before, so that's cheating.
Is that cheating?
I haven't seen it before.
Okay, well, I shall let you answer.
It's not in the numbers.
No?
Either.
Yeah. Can you find the mistake? See, it's really annoying when you see it, and it's really good fun to pick surgeons and anaesthetists against each other, aren't they? But anyway, this slide is designed to hoodwink you. Yes, there's the numbers with the different colours, there's different size fonts and all of that. But this exercise is somewhat analogous to the service in that when you are in a pressurised environment, 5 more seconds to go, it's easy to miss small things. And in the service, when you are constantly doing and doing and doing, we all know that's possible. And the pushback tends to be, well, yes, reflection is great. Of course it is, if done right, reflection, not rumination. But service delivery has to come first, because our patients need that. Yeah. But what is the efficacy of service delivery if you're constantly doing without making that space to think? It will fall apart, and you will fall apart. And finally, when people tell you, no, you just have to get on with it, show them this slide, it's not meant to be pejorative. I just like it, and it reminds me of a group of my F1s who I've been teaching for some time. And they had concerns about the design of the new SCABU, a new special care baby unit, and they went to the service managers who said, no, your job is just service delivery. You're not allowed to get involved with this. Fortunately, they knew our guidance. And here's a thought that I would really like people to remember. They used it as a lever. Because that guidance, as I said before, not edicts from up on high, but a recognition for them that actually we have to be involved in this. It's a requirement, and our trust must facilitate that. And okay, they had a supporting FPD as well. They didn't just barge in and say, look, here's leadership and management guidance. But they knew they were able to use it that way. And it's a really nice story because 3 of them ended up in the group doing that service redesign, because of course they were there right till the end of F2. So when you're being asked to do more for less, and actually it's not working because it doesn't meet our standards, could you use the guidance that way? There's lots of thoughts that I've thrown out there, and I appreciate some of the conversation was curtailed when I had my technical and logical nightmare, and apologies for that. That quote to finish on is from the Secretary of State, former Secretary of State, I hasten to add, who recognised 10 years ago that our role should be along these lines. And I'm really keen that my team work with you to learn how we can support that agenda and the topics that we've been covering this evening. Because another thing that my team do, besides the teaching and listening, we do go back, well, I go down to London every few weeks and inform the policy teams of what needs to change. And that's the reason that revalidation is being reviewed, was reviewed by Sir Keith Pearson, actually. It was your feedback on the ground. So I hope that was helpful. Thank you for your time.